You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 25th, 2024. This week, some listener feedback on pulse field ablation and NSTEMI, oral Semaglutide, symptomatic versus asymptomatic AF, and the win ratio. First, an announcement. This Week in Cardiology takes next week off. I'm in Curitiba, Brazil at the Brazilian EP Society meeting, and they have me quite busy. I will see you the week after, and we'll do some AHA preview news. So first, listener feedback. I want to say I really appreciate the feedback that I'm getting. I learn a lot from it, and thank you. On PFA, I received a cautionary email from a very prominent ablation doctor in Europe, and he wrote to me, John, I share your enthusiasm for PFA. It is an absolutely fascinating energy source that may revolutionize EP. However, at present, we do not have data indicating that PFA is either safer or more effective than cryo or RF for PVI, as demonstrated by several studies, including the Advent study, which I've covered previously. He writes that I'm particularly concerned about the inappropriate use of the Farapulse catheter for treatments in addition to PVI and posterior wall isolation. At the Asia-Pacific HRS, data presented by Tam et al. Highlighted this concern. They performed coronary angiography and OCT prior to and 3 months after right atrial flutter ablation with the Farapulse catheter and found a 30% stenosis 3 months post-ablation, with stenosis increasing up to 60%, and then stenotic area encompassed the entire region of the PFA lesion in the cavo-tricuspid isthmus. And he continues, until we better understand this energy source, I strongly believe we should avoid using this catheter near coronary arteries. And then he writes that I've highlighted the most worrisome complication following AF ablation is the atrial esophageal fistula, and that the PFA provides peace of mind in this regard. However, my colleague writes that we know cardiac tamponade remains the most common lethal complication following AF ablation, and there seems to be a trend toward a higher rate of cardiac tamponade, including fatalities in the PFA literature compared to cryoablation, and this may be due to catheter design. Additionally, we do not know whether there's any risk of atrial esophageal fistula following PFA. He tells me that his group has recently published findings indicating that a significant temperature rise in the esophagus greater than 40 degrees Celsius can occur during PFA ablation. My colleague feels that we have not yet treated enough patients with PFA to reach a definitive conclusion on AE fistula. He reminds me that we once believed that AE fistula was not a concern in patients undergoing cryoballoon pulmonary vein isolation until we treated a sufficient number of patients. And of course, all electrophysiologists have recently received a warning from Boston Scientific due to a high rate of AE fistulas following cryoballoon ablation with their catheter. They have seen AE fistula in 7 patients. My European colleague wanted to emphasize the need to treat more patients with PFA before determining whether AE fistula is a concern. And to the best of his knowledge, about 70,000 patients have been treated with PFA, which is not enough to draw a final conclusion. And he concludes with the sentence, I firmly believe that in the interest of our patients, international societies must establish a high-quality reporting system for device-related deaths and serious injuries. I have to say that this email caught me by surprise because I've been using PFA now for a few months, and I'm quite struck by its safety, its efficacy, But again, it's a small number of patients, and so I appreciate the concern, especially from such a prominent ablation expert in Europe. Next bit of listener feedback had to do with my non-STEMI STEMI take last week. I reported on a provocative state-of-the-art review paper in the journal JACC Advances. The first author of that paper was James McLaren, and he and his co-authors argued for a new paradigm shift in acute MI. Now, it's hard to recap the whole thing, but the gist of it was A, that the STEMI paradigm, which stems from ST elevation seen on the ECG, is a poor surrogate for coronary occlusion, and thus there are some patients who have delayed reperfusion therapy. The second take-home is that there are new advances in ECG reading with artificial intelligence that may be able to identify subtle ECG findings, which will better allow us to identify patients with occlusion MI. And finally, the third gist was that the whole language of non-STEMI and STEMI prevents improving the finding of occlusion MI. Why? Because if someone comes in with a non-STEMI, but it's an occlusion MI, the occlusion MI is missed, right? There's wall motion abnormalities, there's troponin bumps, cardiac damage ensues because there was not reperfusion therapy. But this never falls out as a miss because it's just called a non-STEMI. I spoke favorably about the change, but an interventional cardiologist from British Columbia wrote in opposition to my favorable view of this occlusion MI paradigm change. I'll read you what he wrote. It's pretty short. He writes, first, primary PCI is the default strategy in STEMI, which is defined as greater than 2 millimeters of ST elevation, 3 or more contiguous leads. And despite sharing very similar pathology, thrombolysis has not been demonstrated to be beneficial in non-STEMI, even though this inevitably includes individuals who have occluded vessels. A default strategy of primary PCI in non-STEMI has not been tested, so the option of going urgently to the cath lab is always possible for those non-STEMI patients that fail to settle with initial medical management, and indeed he's right that the early invasive, especially in higher risk patients, has been shown to be better than conservative strategies in non-STEMI. He goes on, second issue, the ultimate aim of primary PCI in STEMI is opening the infarct-related artery to reduce significant LV dysfunction and thus reduce morbidity and mortality. ACS cases with less severe ST segment elevation, i.e. non-STEMI, are associated with less significant LV dysfunction. Whilst the culprit vessel may be occluded, such cases are often due to occlusion in small side branches, non-dominant circumflex arteries, or larger epicardial vessels which have pre-existing collaterals with associated less myocardial damage and thus less likely to benefit from immediate opening of the infarct-related artery. He goes on and says, physicians with less skills in interpreting ECGs than yourself or the authors may initiate, as you term it, cardiac cascade, i.e. referring all ACS patients, STEMI and non-STEMI, for primary PCI. While STEMI and non-STEMI definitions may not be anatomically specific, they are functional, and concludes that by writing that he is skeptical that the proposed changes in ACS definitions and subsequent management will be successful in improving outcomes. And I love this comment. It made me think. And he's right that lytic trials did not show a benefit in non-STEMI, though I am not sure that translates to it not working in PCI. I went back to look at their table of missed STEMI ECGs in the McLaren et al. Paper, and indeed, most of those non-STEMIs were actually subtle forms of ST elevation or acute injury. My colleague in Canada proposes that we have trials using this new occlusion MI paradigm. And I cannot disagree with that, of course. These trials would have to be large, cluster randomized trials. It would be a big project, but one worth doing, in my opinion. Okay, first topic today is more positive news with GLP-1 agonist drugs. By press release from Novo Nordisk, we learned this week that the oral Semaglutide demonstrated a statistically significant 14% reduction in the risk of major adverse cardiac outcomes, MACE, in the SOUL trial, SOUL. SOUL is a randomized, double-blind, parallel group, placebo-controlled cardiovascular outcomes trial comparing oral semaglutide, 14 milligrams once daily, with placebo, both in addition to standard of care, in 9,600 individuals aged greater than 50 years with type 2 diabetes and evidence of atherosclerotic coronary disease, cerebrovascular disease, symptomatic peripheral artery disease, and or CKD. The primary endpoint was a composite of cardiovascular death, MI, or stroke. The benefit of semaglutide was noted on top of SGLT2 inhibitors, which were used in half the patients. The press release said Novo Nordisk will apply for a label extension for oral semaglutide. They also said trial results will be announced next year. Now, I don't love the press release business, but me not liking it doesn't really matter. Notable, I guess, is that a 14% relative risk reduction in a composite endpoint is not that much. We'll have to wait and see about the components of the endpoint, and I'll discuss components of the endpoint when I discuss the win ratio at the end of the podcast. Next topic is the issue of symptomatic versus asymptomatic atrial fibrillation. The European Heart Journal has published an extensive meta-analysis of studies looking at the association between symptom status and clinical outcomes in patients with AF. Now, it's a historical thing, symptomatic versus asymptomatic AF, but the era of digital health is changing things in AF care. Not well known is that nearly half of patients with AF have no symptoms. At least that was in the past. This study, from a team in northern Greece, first author Dr. Paskalis Karakassis, found 36 studies with over 200,000 individuals. Of these 36 studies, there were 5 RCTs. They studied outcomes: mortality, CV death, stroke, hospitalization, heart failure, and AF progression. And here were the findings, some of them interesting. For all-cause mortality, 21 studies involving 176,000 patients, the authors found no difference between symptomatic or asymptomatic AF. Same with cardiovascular disease, same with stroke, and there was also no difference with hospitalization, so for hospitalizations, the confidence intervals were wider. The big differences came with new onset heart failure, which was 33% higher in symptomatic AF, and the outcome of AF progression, which was 30% lower with symptomatic AF. Though in this AF progression outcome, it did not hold up in a second statistical method using Bayesian analysis. The point estimates, though, were similar, and the different statistical methods are beyond my level. My comments. The last outcome of AF progression makes sense, right? If you have symptoms from AF, doctors are more likely to intervene and stop the AF progression because of symptoms. The authors write, and I did not know this actually, that the most recent ESC AF guidelines say that asymptomatic AF is independently associated with an increased risk of stroke and mortality compared with symptomatic AF. This study does not seem to find that, and the authors suggest that AF stroke prevention should be less influenced by the symptoms and more so by patient-specific factors such as those outcomes in the CHADS-VASc score, for instance. And I agree with this, but the authors do something that I don't exactly agree with. They write strongly in support of rhythm control strategies, and they cite papers like Early AF and East AF and a recent meta-analysis in Jackie P., all of which find benefits of early rhythm control. But I would push back on their highly favorable view of early rhythm control a little bit. Their data, looking at symptomatic versus asymptomatic, doesn't really support comments on the value of rhythm control. It simply suggests that patients with and without symptoms have quite similar outcomes other than heart failure and AF progression. I highlight their meta-analysis because modernity is changing the ratio of symptomatic to asymptomatic patients with AF. It's really kind of important. Now, here is the frequent occurrence, right? A patient who feels well, no symptoms, they're not even a patient yet. They buy a smartwatch, which then tells them that they're having AFib. Say it's low burden AFib. The watch documents, they take a rhythm recording that is actually AFib. The patient felt well. Note the past tense, felt well. The knowledge of the AFib now makes the patient feel somewhat unwell. Now, proponents of AF screening might say that this is a good thing, and I would agree if two conditions are present. One, that the episodes of AFib are long-duration AFib, perhaps even persistent AFib, and two, that the patient is super high stroke risk, because in this case, It is likely or maybe possible that initiation of oral anticoagulation may be beneficial, though you would be correct in citing all of the negative screening studies, such as the Loop trial, Artesia, and NOAA. But many of the patients with previously asymptomatic AFib are made symptomatic by knowledge of the AFib, and they might have low stroke risk and low burden AF, and these patients are at risk of being overtreated by well-meaning doctors. The authors of this meta-analysis write that AF progression rates are unacceptably high, considering that persistent forms of AF associate with worse outcomes. But I am not sure what AF progression rate they would be happy with, since the number one cause of AF progression is aging. This meta-analysis finds little difference in outcomes based on symptoms, which I would use as a somewhat reassuring factor with patients. In general, AF as a condition is changing. Gone are the days where most AF was diagnosed on 12-lead ECGs, which were done because of symptoms. Increasingly, we will find AF early. Whether this is a good thing remains to be seen because A, we know from Artesia and NOAA that short-duration AFib surely confers a lower stroke risk, and B, many of these patients with low-burden AF do not progress or even regress, and they may receive potentially risky rhythm control strategies such as drugs and ablation, which won't help them. Finally, whenever I speak about overtreatment of AFib, which is prominent in profit-driven health systems like the one I'm in, I also want to recognize that there is also undertreatment of AFib as well. People often tell me of patients with AF that don't get to see electrophysiologists who could have stopped the progression of AFib, and I understand that. The care of patients with AFib is tough because it is such a diverse condition, and it can range from not a problem at all, somebody has one episode of AFib with drinking too much wine, for instance, to a very life-threatening condition where someone has AFib and it puts them into heart failure. But that is why I like taking care of patients with AFib so much. Namely, you have to be a good clinician. A robot with artificial intelligence can't do it. All right, I want to talk about the win ratio. The European Heart Journal has published a very readable review of the win ratio. The first author is the famous Stuart Pocock. I discussed this statistical approach because it is increasingly being used in cardiology trials. But, please, I discuss it from the viewpoint of a regular doctor. I am no statistician. The reason I think this is an important topic relates to one of the most common questions I get when I speak, and that is, what do I think of composite primary endpoints? As I said in my talk last week at the University of British Columbia, in the days of old, cardiology trials measured one thing, alive or dead, mortality. You barely needed any statistics, and you surely didn't need a win ratio. But times have changed. Many of the big wins in cardiology have already occurred. Reperfusion therapy for MI, for instance, ACE inhibitors, beta blockers, and MRAs, and HFrEF for another. Of late, though, it's harder to show differences in death. So cardiology trials have embraced composite outcomes. And it's not necessarily a bad thing because many of the components of these endpoints are good things to prevent, such as hospitalizations or strokes. And in blinded trials, quality of life is also a very important endpoint. The problem with these composite endpoints, which is partially solved by the win ratio, is that not all of the components are as important. So we sometimes say hard versus soft outcomes. The CLEAR trial, for instance, of bempedoic acid versus placebo had a positive 4-component endpoint, but it was driven by coronary vascularization and MI, but cardiovascular death was unchanged. This led the authors of the review paper on win ratio to write, quote, "Conventional composite endpoints do not directly take into account the fact that the component events may well vary in their clinical importance. For instance, deaths are more important than non-fatal events." Of course, that's correct. And this is where the win ratio comes in. The win ratio is a hierarchical score that considers the importance of the outcomes. For instance, in a heart failure trial looking at death and hospitalization, death comes first, hospitalization comes second. Now, I want to be careful here because it gets a little technical, but my understanding is that the win ratio takes patient pairs, the treatment versus placebo. Now, obviously, there's a lot of patient pairs in a trial of thousands of patients, so you need a computer. And you compare, of these patient pairs, which one has the outcome. If the patient on new treatment does better, it is called a win, whereas if the control patient does better, it is a loss. If neither pair has the first outcome, say death, it is a tie, and then you go to the second hierarchical outcome. Eventually, there's a tally, number of wins divided by losses, and hence the win ratio. The authors of the paper use examples of trials such as Partner, COAPT, Triluminate, Emperor Preserved, and others. They discuss how win ratio is a relative risk score, but it also can be used to estimate an absolute risk difference by presenting what's called a win difference. For instance, in the Partner trial, TAVI versus SAVR, the win difference was massive at 26%. But in Emperor Preserved, which was EMPA versus placebo in HFpEF, the win difference was nearly nothing at 1.9%. Now, of course, the win ratio can also be applied to quantitative outcomes, such as things like the BNP or the KCCQ. The positive of this is that you can use more of the data from a trial. And statistician Frank Harrell from Vanderbilt talks often about this online, namely that you don't want to waste data from trials. The problem I see as a person who uses this data, and the authors outline this issue, is that in cases like the DAPA-MI trial, DAPA versus placebo in post-MI patients, here the trialists used 7 components of their primary endpoint, and it went from increasing importance of, say, death, then heart failure hospitalizations, then MI, but then the trialists added AFib, type 2 diabetes, New York Heart Association functional class, and even a weight decrease of more than 5%. So the main outcomes, the important outcomes in DAPA-MI were all the same, but the win ratio was positive when it was based on these latter, less important outcomes. This review paper is worth your time. It is very well written. The examples are great. The underlying theme here is what we measure in clinical trials is at the core of evidence appraisal and translating evidence to our patients. And there's tension, right? Because on the one hand, really strong therapies hardly need statistics. You can consider something like the RAILS trial of spironolactone versus placebo, and spironolactone in HFrEF patients just had a massive reduction in overall death rate. But such a view may be too nihilistic. In modern times, prevention of important outcomes such as hospitalizations or improvement in quality of life are also important goals. The question comes when these non-fatal outcomes are better with a new treatment, we all must make value judgments. The win ratio can't help us decide if an SGLT2 inhibitor is worth adding when it costs a patient hundreds of dollars per month. Another place that win ratio can't help us is when an endpoint is biased. A classic example here is Triluminate, which was transcatheter repair of the tricuspid valve versus medical therapy. In this trial, the objective outcomes, death, tricuspid valve surgery, or heart failure hospitalizations, were not different amongst the two groups. In other words, they were ties in the win ratio. The difference came in the patient-assessed quality of life score, the Kansas City questionnaire, which was positive for the device. But the win ratio cannot rescue the fact that you can't compare subjective endpoints when one group gets a procedure and the other group gets tablets. I mean, there's a clear placebo effect. I really love this paper. I learned a lot from reading it. I'm going to bookmark it. I think you should too. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider giving us a rating, writing us a review, give me feedback. I'm learning a ton from listener feedback, so thank you very much. And I'll see you in 2 weeks, and we'll talk about the big studies coming up at the AHA. This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.